Assalamu alaikum. This is Dr. Salma delivering lecture from Faridpur Medical College, Department Radiology and Imaging. We are going to start with clinical cardiac radiology. How junior students like you can read cardiac abnormality, the chest X-ray displayed. This is our primary issue to make you develop in a way that you can read the chest X-ray and find out any gross cardiac abnormality, whether it is present or not. I used to talk in English because in my medical life, I never had a lecture in other language. If you have any objection, if you have any problem, you can share me, right? I like to continue it in English. If you have any other options, we can talk about later. So this is clinical cardiac radiology. We are going to start. Before going to read a chest X-ray to be identified to be any cardiac abnormality present, we should go for the normal cardiac anatomy. Then we'll go for the situs, the normal contour and normal vasculature. In the chest X-ray, the normal heart is, in a standard chest X-ray, I should say, the 1/3 of the heart is to the right of the midline and 2/3 to the left of the midline. So that in a standard chest X-ray, the main cardiac mass is to the left. Would it be on right side? Yes. Some rare cases it would be on right. That is our later discussion. Now we are going through a normal situs, a normal person having a main cardiac mass to be on left side. The small part of the heart on the right side of the midline is displayed as right paracardiac, the right paramedian and paraspinal convex shadow on right hand side of a person. So the main cardiac mass is to the left of the midline. And what about normal cardiac dimension? The normal cardiac dimension is up to 50% in standard PA chest film taken in full inspiration. What is that? The normal cardiac dimension, how it is measured and how it is declared to be 50-60%. That is the question. I know that you are now thinking of how it would be 50%? The answer is here. You take a vertical line over the spine in the midline and draw the maximum convexity of the right heart border from that line and the maximum convexity on the left side of the line, and these two here, it is measured from this line. Line A is on right side, maximum convexity point to a vertical line over this midline over spine, and the line B is the maximum convexity of the left heart border, and this A and B are measured to be a part of percentage of this line C. This line C is a line drawn just above the CP angles, joining the internal, is displaying the internal thoracic dimension. You see, it is not reaching the CP angle, is far from here, just it is above the CP angles and is displaying the internal thoracic dimension. This is line C. So the line, the dimension A and plus B should be up to 50% of line C. And this is a good thing I need to discuss really in our context of this country, and I should make you to remember these things before I jump from here. The standard chest X-ray is very, very important for us to understand this 50%, to understand the line A, line B, and line C, and what is the standard, and how far substandard we are dealing, you will come to understand. And why it is necessary to know, you will come to the know at the end of this session. And in the standard film, we know the patient faces the film and the chest is pressed over the film cassette, chin upwards, shoulder internally rotated and backwards. These are the theories. You need not to make it to just recite. I just want to display a scenario that how a patient is exposed during X-ray to be taken. The patient is asked that he or she is made to stand up with his film in front and the hands at the back of their waist, so that there is an internal rotation is made over the shoulder, and the scapular placed outside the chest. These lung fields are exposed and the scapular are kept out of the lung fields, and the exposure is to be taken in full inspiration. The patient is asked that take a long breath And the field focus distance is also a matter here. Whatever. The patient is asked to take a full inspiration. And the thing happens here because this is the first time for a patient to be exposed. This is not a matter that every day patient goes and an X-ray is done. It's no. In one's lifetime, it may be single or twice exposure or chest X-ray is done. So the story of take a full inspiration is really difficult to make and really difficult to interpret the chest X-ray. Because it should be, the standard should be, one should show him or her that when I will say you take a long breath, in Bangla it is said that শ্বাস লম্বা করে নেন, শ্বাসটা ধরে রাখুন. Someone is to make it a display that do it. I am telling and I am doing it. When I will say you, you will do the same. But there are the luckiest scenario working throughout the Bangladesh that not a single X-ray is taken, at least at the periphery, not the standard diagnostic center. The all over situation is no full inspiration is made, no authentic X-ray is taken, and no standard film really produced. So what is your job? Let's go to the radiology, cardiac radiology. Whenever a patient is not taking a full inspiration, that is the substandard chest X-ray, that is the poor inspiratory film. You will see most of the X-rays are written in this language. This is a poor inspiratory film. And what happens? This poor inspiration causes the diaphragms to be elevated. And whenever the diaphragm is elevated, the heart has got its transverse dimension more than usual, and there is more basal vascular crowding that is making a misplay of cardiomegaly and bilateral basal haze that is not expected in a normal person. So whatever 50% or 60% you are going to produce, you are going to decide from a chest X-ray, you must go through the standard inspiration status of the X-ray. How it is possible to understand that whether this X-ray is taken in at the height of full inspiration? A normal respiration takes the heavy diaphragms at inspiration at anterior 6th rib or the equivalent is posterior 10th rib. Can you hear me? So you go through that, these hemidiaphragmatic levels where there are so many causes that the hemidiaphragms retains higher than normal in inspiratory phase, or there are situations where the patient really cannot make a good breath to push the hemidiaphragms down. So the poor inspiratory films are really making us embarrassing to declare a patient to be anormal or abnormal. So the first thing, you make sure that the X-ray is taken in a standard full inspiration. Otherwise, you clinician is going to do a mistake, and me radiologist is also in moderation that whether there is anything else behind the cause of this poor inspiration. So mistakes may play a role in between. If the patient has got a good inspiration, the normal cardiac dimension is up to 50% in standard PA chest film taken in full inspiration. Mind it, the X-ray should be taken in full inspiration. And for the Asians and elderly people, it is a bit more than this dimension. It is taken as 55%, and in the children, it is 60%. In neonates, the PA and AP films are carrying the similar values. So if you don't need any queries to take an erect film in neonates, you need not to arrange the scenario to hold the child hang up with the hands of the parents. Don't need it, because the AP film and PA films are carrying the similar values in cases of chest X-ray. There are some issues that the baby needs an erect film, like in perforation, to find out the air fluid levels, like this. So that is the different situation. But in routine cases of neonatal X-ray, it can be made as a PA or AP is the same. So you can take it as a same. This film I already discussed. This is chest X-ray PA view. What is seen in the X-ray standard X-ray film. You see, this is a good X-ray film because the hemidiaphragms are depressed down enough to have a very good lung fields to be started. The anterior 1, 2, 3, 4, 5, 6. It is at the level of 7th, anterior 7th rib, and it should be corresponding to posterior 11th rib. Usually 4 ribs are making the distance from anterior to posterior ribs. Now, what are the structures forming the cardiac contour? And that is the chest X-ray displays what we should now can discuss about. This is the right border of the superior mediastinum is formed by the superior vena cava and innominate veins, and this part is the right atrial border. And what about this? This is the subclavian artery. This is aortic knuckle. This is the pulmonary trunk, and below the pulmonary trunk is the area for the left atrial appendage, and this convexity is made by the left ventricle. In the lateral chest X-ray, the heart is in the middle mediastinum and it is retrosternal. We know it is retrosternal. So the cardiac surface behind the sternum is formed by the right ventricle. And from this right ventricle, this area is formed by the right ventricular outflow tract, that is the pulmonary trunk that arches back below the aortic arch. And this is the aortic, ascending aorta and aortic arch is here. And this part is made by it is seen. These vessels are the pulmonary veins and left atrium is making this anatomical area, and below this area is formed by the left ventricle. And this area is formed, this is a faint shadow, is formed by the inferior vena cava. And that is written in black and white. The normal cardiac contour is contributed by the followings. In PA film, it is superior vena cava, the right atrial border on right side, the aortic knuckle, the left pulmonary artery at the level of the hilum and the left ventricle. This aortic knuckle, pulmonary trunk, this area left atrial appendage, and this is left ventricle. Because this is the pulmonary trunk that gets division into the left and right branches, so these would be at the level of the left hilum. So any structure above or below or at the hilum can be a part of discussion in relation to this pulmonary trunk anatomy. Again, the lateral view, I have said that it is the anterior surface of the right ventricle and right ventricular outflow tract is forming the anterior cardiac surface, retrosternal surface, and the arch of the aorta along the anterior aspect, and the posterior aspect, the left atrium in the upper part, and the lower posterior aspect is formed by the left ventricle. And next, we can go for the discussion about situs. The small things I like to highlight, not the total thing I am going to, because this is something else we have to know very well. What is situs and what is situs solitus? What is dextrocardia with situs solitus or levocardia with situs inversa? Sometimes we used to describe sometimes, and I have said that heart is of course only the left side, but there are some situations where the heart, the very rare situations, the heart is on the right side of the spine. And this is a very interesting thing that one of the noble owner in literature has the Nobel Prize just depending on this medical information that at that time the thorn is introduced into the left side of the heart, and the villain was trying to kill the hero, and he did it. The thorn was introduced to the left side of the chest cavity to kill the hero, but surprisingly, the hero was not dying, and the villain was defeated because hero has got dextrocardia. And this is a chest x-ray where the heart is on the right side, but the gastric shadow is containing air under the left dome of diaphragm. If you have any confusion, why this is a gastric shadow, this is another chapter we can discuss later. This large soft tissue area is produced by the largest organ, endocrine organ, mixed organ, not only endocrine, this is mixed organ, like this is produced by liver. And on the left side, there are the colonic shadows and the gastric shadows occupying the left hypochondriac region. So the liver is on the right side and the stomach on the left side, and that is very important parameter to declare the actual situs status. So only the heart is on the right side and the abdominal organs are in normal position. This is called dextrocardia with situs solidus. There is a possibility of cardiac diseases, cardiac congenital and developmental diseases in cases of normal situs, but in cases of situs inversus or any abnormality of the situs, they carries the higher values of possibility of congenital and developmental cardiac diseases. So that is the morning question for us to come to discuss this dextrocardia. We are talking about the left and right sided heart so that we can memorize it in our practicing life. And this is dextrocardia with situs inversus. Sometimes say situs inversus totally, because the heart is the main cardiac mass is on the right side, because the apex is on the right and a small portion is here. The diffuse soft tissue mass by the liver is produced on the left side, and this gas shadow, funding gas shadow is here on the right side. So this is dextrocardia with situs inversus. One thing I should go for this, this is the vascular pattern of the lung fields is another very important issues we should discuss, that the vascularity pattern of the normal lung is there is the pulmonary trunk to be here and the left and right pulmonary arteries is running downwards and the basal vessels are denser than the apical vessels and the vessels are tapering toward, these are the branching vessels, and it tapers to the lateral third of the lung fields. This is the normal vasculature. The density and the caliber of the vasculature is more at the bases rather than the apices are clearer, and the caliber is less because of the gravitational force is working to produce this scenario. This is the normal vasculature, and there are some dimensions also that we can recall. Just mind it that the cardiac dimension in a full inspiration film should not exceed 15 centimeter. What I said, it is not more than, should not exceed more than 15 centimeter, and this pulmonary artery should not be more than 15 millimeter. And you can also be agreed with me that there is some prominent vessels also in the upper part, few prominent vessels, but even then the basal vessels are prominent and the upper zone is better clearer. So this distribution to the periphery is normal. Again, this film is normal also, carrying the similar pattern of the pulmonary vasculature, that these vessels are tapering down and the denser vessels are at the bases and the apices are clear. There is another term. I am not going to discuss it very large scale, it need not. There is a situs called situs ambiguous. Sometimes the situs is undetermined because of the persistent early fetal bilaterality in varying degree. It means the development during the fetal life produced the similar bilateral right-sided or left-sided. It is the mirror copy of the both lungs, and also the both cardiac chambers would be the similar. There would be right-sidedness and left-sidedness as bilateral event. There would be both right-sided lungs or would be both left-sided lungs. And ambiguous is what? I hope I got only 2 cases of situs ambiguous in my practicing life, where the liver is horizontal and there is similar lung fields on both sides. So how can we understand that both the lungs are right or left? You know, the right lung has got 3 lobes produced by short and long fissures. Long fissures are present in both the lung fields, but the short fissure is only present in the right lung. This short fissure is in a substantial cases, the horizontal fissure is seen in the chest X-ray PA view. So this presence of this horizontal fissure on both sides makes a declaration of bilateral right-sidedness. And what about the tracheal division and the principal bronchus history? The right principal bronchus is shorter, straighter, and wider. And what about the left principal bronchus? This is a longer bronchus than the right one and is more oblique. So, and the ratio between the right and left principal bronchus are 2:1. This ratio means that the left principal bronchus would be double to the length of the right principal bronchus. If this two bronchus has got the similar length or similar, or the ratio gets reduced to 1.5 or 1, then there is a suspicion of the situs abnormality of bilateral right-sidedness or left-sidedness. I don't know that whether you have come to understand or not. You make me text so that I can try to make you the answer to be understand. Here, the both lungs are trilobed with apertorial bronchus. In the bilateral right-sidedness, there would be absence of spleen. Liver is central and symmetrical. Gallbladder is on either side, on any side, and the lungs would be oligemic because of the pulmonary stenosis or atresia. This is Situs inversus. With the liver on left side. So this is Situs inversus. You see that this is a chest X-ray of a neonate in an ICU because there are multiple channels present here. You see that this X-ray has got a normally positioned heart, but what is there? There is a clue to be situs abnormality, as this NG tube has got a right-sided position. We know that the stomach should be on left side and the gastroesophageal junction is on left side, and the NG tube goes in this way, not in this way. NG tube should run on left side. So this is a case of situs inversus. And the bilateral left-sidedness syndrome or asplenic syndrome is present to be when the lungs are bilobed with the hyperterial bronchus. There is absent gallbladder, multiple spleen, and there is plethoric lung fields due to left to right shunt. And another pointer of polyasplenia is large gyrgos vein. So the next week we are going to discuss with other things. Do you have any question? You can ask me on Messenger and I shall try to make you. Do you have any question? If you don't have, then we are going to conclude the session. So if you don't have any question, we are going to stop the class. Thank you for your patience sharing, and let's try to understand radiology as a very interesting and very useful tool if you come to understand. Thank you.